Hello, my name is Cameron Sabat, and this is Cutting to the Case, today with Dr. Ali Khan. Dr. Ali Khan, MD-MPP, FACP, is a practicing general internist and the chief medical officer of Medicare at Aetna of CVS Health, where he advances strategies, policies, and programs that drive the delivery of clinical excellence, clinical impact, and superb member experience for Aetna's over 11 million Medicare members nationally. He joined Aetna from his prior role as Chief Medical Officer of Value-Based Care Strategy at Oak Street Health, where he led efforts in managed care strategy, medical management, clinical design, workforce development, and public policy. Ali joined Oak Street Health in 2019 as Executive Medical Director of the 8-state 60-plus center Heartland Division and continues to practice general internal medicine at Oak Street's clinics on Chicago's west side. Prior to Oak Street, he served as CareMore Health's clinical design officer and in leadership roles at Iora Health. Ali serves on the faculty of the Yale School of Medicine and Northwestern's Kellogg School of Management, on the Harvard Kennedy School Healthcare Policy Leadership Council, and is a director on the American Board of Internal Medicine's Internal Medicine Specialty Board, the American Board of Internal Medicine Foundation, and the Better Medicare Alliance. Thank you very much for joining us today.
Thanks for having me, Cameron.
Yes. And, I wanted to start out by just thanking you for joining us on this podcast, as well as asking about your career. So you've built a very interesting career that spans clinical practice, academia, policy, and corporate leadership. I'm sure the viewers want to know this as well. How did you decide when to transition between these domains?
It's such a good question. So I would say this was probably the running thread throughout all of this as I was thinking about a career in medicine. So, like you, went to high school in Vienna, Virginia at the Flint Hill School, and spent a lot of time there sort of dreaming that I would become actually like the next great American investigative reporter. Whereas my parents probably had other ideas in terms of trying to figure out how I would fulfill my genetic destiny as a South Asian male and like somehow go into medicine, right? So, lo and behold, I end up in an 8-year combined undergraduate and medical school, like a BSMD program down at Virginia Commonwealth, and spent a lot of time trying to figure out like, could I merge these sort of worlds together in terms of what I would probably broadly frame from like a medicine perspective and then like society. So I think I've tried on a bunch of different hats in that society, arena, trying to think through like, is it reporting? Is it writing? Is it health services research? Is it law? Is it management? Is it whatever? And I would say, that was the better part, Cameron, of probably like a 10, 12-year arc, even through the pieces of like, hey, go from undergrad, do I go to medical school or not? Okay, decide to go to medical school. In the middle of medical school, spent a lot of time thinking about, I want to do medicine plus something else. What is that? What kind of degree should I get? Should I go to law school? Should I go in the middle of med school? Should I go get a PhD? Should I get a master's in economics? Should I go get an MBA, whatever? And, end up going to get a master's in public policy because that felt like the best fit from what I was thinking about from a federal perspective and just like from a change agency perspective. And then, decision whether or not to go to residency, right? Decide to go to residency and then even in my years in internal medicine residency, I probably was still the hypothesis that I had when I started residency as an intern about how my career would be able to do medicine plus shifted dramatically by the time I graduated, right? Like I did not imagine in any form that I would end up certainly where I am today with, a career that's been 15 years in the private sector. But I'll say this, I spent a lot of time figuring out that like I liked building things, I liked bringing people together, and I liked solving, or rather getting my hands dirty and trying to solve the harder problems to kind of fulfill the promise of healthcare reform, right? Being lucky enough to be a medical student sort of in the late 2000s, very much part of like sort of a lot of the momentum and a lot of the policy work around the passage of the Affordable Care Act. And then to see sort of like what post passage ACA implementation looked like sort of told me that, hey, this is a moment to really think about how do you do, not necessarily how do you legislate or how do you study. And I think that kind of guiding principle has been kind of paramount in thinking about what opportunities I've just taken from a career standpoint.
Yeah, yeah, certainly. And, it sounds like there were some pivots there where you had an idea of where you wanted to go and kind of swam in a new direction. And I wanted to know what lessons from this medical training, from which you had some reservations as you were going through it, thinking whether you should go to residency or not. What lessons from your training at Yale Med and Kellogg have proven most valuable in your leadership role at Aetna CVS Health?
Great question. I think I think it drills down to sort of three questions that I ask myself anytime I'm joining a team or leading a team or thinking about what to dive into, right? From whether it's subject matter expertise or a problem to solve. So I think first is like, is this a problem that I care about? Right. And so for me, I think the overarching one has been where and how am I thinking about or helping to contribute to problems that in the underserved and in particular the urban underserved face day to day in the gamut or the gauntlet that is trying to become healthy in America and what that requires, what that means, and what the difficulties therein. And so, like, how am I helping to kind of contribute to the problem that I solve? There's a lot of interesting stuff in healthcare, and there's a lot of interesting stuff in medicine. And I think a lot of us can get distracted. I think right now is a really critical time where I talk to a lot of medical students or trainees, and they're like, should I be thinking about AI? How should I be thinking about technology in my world? And it's very, very easy to kind of get on the soapbox and say, hey, you should definitely do this, right? But it has to be something you care about, right? Like the things that I care about, my wife, who's a global health specialist and a reproductive endocrinologist, does not care about at all, right? So like you have to be able to follow your own path and actually drive towards something that matters to you, right? So that's I think principle one. Principle two is like, what am I going to learn? Like, am I going to grow from this experience? How am I thinking about or contributing to sort of that like T-shaped personality, right? That a lot of people will think about in terms of their own personal development. I'm not saying like the T concept is the only motif to follow, but I do think that in many careers we can often. I was listening to a great podcast this weekend talking about how we often narrow as we go forward and we get older, and the folks that tend to become really transformational leaders are constantly thinking about how to expand, how to throw themselves in different environments, develop the kinds of sets of skills that enable them to survive and thrive in different environments, and then move forward, right? So I think that's number two of just thinking through that piece of, how does growth come from diversity? And then third, Cameron, really simply, I think there's something really important to be said about being around people that you want to be awake with at 2 o'clock in the morning, right? And that's how I picked a residency program. That's how I like have thought through a lot of things. But if you aren't finding folks that you're immediately aware that you can learn from, that you're inspired by,
Mhm.
that are going to push you but also support you, and that like you can just have some fun with, right? The work that we take on in medicine, the work that we take on in leadership and management, entrepreneurship, public health, any of these sectors, it's really hard. It's often quite isolating. And while there are thankfully more and more of us on this path, there often aren't natural, like, sort of places for folks to support people like all of us and to keep us going forward, right? And so, like, I was lucky enough in my medical training and undergraduate training to find some of those pockets over the years. And some of those folks I've stayed friends with for 20, 25 years, right? Starting from like, from year one AMSA or PHR, stuff like that. And that ability to sort of just know that you have that community and that you can continue to rely on it and invest in it is so crucial that I come back to that rule over and over again. Like, are these the people I want to be awake with at 2 o'clock in the morning, putting in a central line? And it's tended to work out.
Yeah, certainly look for the people that you want to be with and have the skill set to thrive in various and sundry environments that may come as a surprise to you. I mean,
Yeah.
it's certainly interesting to see how careers have kind of evolved and almost like careers sometimes in some fields don't even exist anymore, where people are jumping from environment to environment, just trying new things all the time. It's just things are growing at such an extraordinary pace. I was wondering on point two, you mentioned that, you were listening to this podcast recently. I'm wondering if you could share with the viewers maybe your top picks for where you get information on healthcare and what are your most trusted sources?
So one of my old standbys continues to be the daily Kaiser Health News daily health policy report, which I like. It's dense, so I don't always get through it every day, but I at least skim. I will tend to pick up a few things in terms of what's happening from a federal and state level through like daily newsletters from like Politico or Axios. That's the growing up inside the Beltway for me. I guess I can't get away from those things. I spend a lot of time on like Sundays reading through stuff like Health Tech Nerds or the AMA's weekly digest, like just again, not only trying to keep pace of like what's happening in industry, what's happening in the profession, right? And like as someone who has, I've led 1,000-person medical group, I spend a lot of time now dealing with physicians and clinicians around the country and health systems and stuff like that. Knowing what's going on and not being like sort of blind to it is non-trivial in this work, right? So like going through that stuff. And then I just kind of mess around with a bunch of random podcasts that I think are helpful. I find in the podcast world, like I go through phases, but like there's a few different healthcare podcasts that like are useful, that bring a lot. LRV Health runs one called Healthcare is Hard that I think is super interesting because again, it's very sort of inside baseball. But then on the other side of things, I listen to a lot of like Scott Galloway and like Pivot and those and like political stuff just to sort of keep things interesting. Amy Schumer's working her way, not Amy Schumer, sorry, Amy Poehler's podcast is working her way in just because I want some comic relief. When again, in a career in medicine or a career in management, like you often are talking about hard, very difficult things, and you got to keep things a little light. So I'd say from that perspective, obviously, like reading widely is important, and I try to challenge my own worldview in terms of reading stuff from across to both sides of the political aisle, trying to understand what folks are saying who are maybe not fans of the private sector, right? And going forward, I'd say last but not least, I spent a lot of time in Health Affairs Forefront. That's just the policy nerd in me. And so I'll end up there quite a bit, particularly when it's about fun stuff as you're going to be diving into in your career around orthopedic reimbursement.
Yes, yes. And there's a lot about reimbursements as well. I'm curious, from your perspective, having led in 1,000-person medical group, um, how do you think about the physician's role in shaping those kind of larger scale health policy and payer strategies that you're reading about in health affairs forefront?
It's so interesting. I remember, so I was, I finished the first quarter of my senior year and I kind of like didn't have anything to do for 9 months before going to medical school and was sort of at this existential crisis of should I go to medical school or not. So I went up to Boston, this is in 2004, and spent almost the better part of a year interning at a health and human rights nonprofit organization called Physicians Human Rights. And sort of was like, maybe this would be interesting. Like it's a mix of global and domestic work. Like a lot of these guys go to law school, they do other things. Maybe that's the way to create change. Like how do you create impact at a larger scale? What was really telling from that experience was both watching it real time, but also hearing it in the stories of like nursing leaders and legal leaders and policy leaders who were involved in this organization to talk about how like, and to see like the unique power of the physician's voice and the physician's perspective in actually driving systemic change, right? Be that policy, be that internal management work, be that, leadership questions, but that at the core, and particularly for a practicing physician, right? Still practicing, which is a big part of why I still practice, to be able to link and take the stories of what we see day in, day out, and the visceral work that we do in the operating room, at the clinical bedside, in a hospital, in the community, at a home, whatever, and to then can be able to contextualize how what those micro stories are reflective of larger social societal ills, larger challenges, larger management challenges, and then craft a path forward. When again, from a medical perspective, the medical and nursing skill sets in particular are very grounded in real-time problem solving, creativity, the ability to handle hard things. And I think when stuff hits the fan, the ability to just check your own pulse, right? And the old house of God rules before you do anything else. Mm-hmm. Those skills are incredibly important and when off-cited in terms of being able to move, whether that's groups of people, whether that's legislators, whether that's policy and action, in any of those milieus, that perspective becomes really critical. And so I was really lucky, Cameron, to see that even before entering medical school, And to be able to hold on to that, right? When you're like in the throes of like gross anatomy and it's like getting darker because like when I took it, it was right around this time of year, and like you smell like formaldehyde, or you're on your third year OB rotation and just like you getting up at 3:30 in the morning, trying to catch some babies and stuff. And you wonder like, why am I doing this? And like that, I mean, it sounds like you can relate, but like understanding sort of that why is critical to so much in change management. And when we think about how we manage our own internal change process, that coming back to those kinds of moments has been very critical for me in terms of just knowing how and where to push forward.
Yes, and truly, I mean, having that why, I'm about to go into a night shift right now for pediatrics. So, speak of the devil. Um, but yeah, I mean, and and when you say that, that's reminiscent of a lot of my friends in medical schools across the country. They want to do kind of what you're doing, this larger scale impact. And so,
Yeah.
I was wondering, ask the man himself. Many students and residents aspire to combine medicine with specifically business or policy. What advice would you give them on preparing for this kind of a career?
Oh, that's a good question. I think heterogeneity of experience is really important, right? Particularly at a moment where, yeah, I still do intern selection committee work over at Yale, and like it's been interesting that over the past 5 years in particular to see the arms race that's developed, right? Like everybody, present company included, has like 20 or more publications coming into residency applications, right? Like research has become like a bare minimum and a lot of research, right? Particularly in the most competitive specialties or in the most competitive programs in the specialty. Um, and it's like people walk on water, right? Like the average step two CK score is up, I think 27 points from when I took it in 2008, right? Like now my score sounds almost embarrassing. Like, so like, but like the people haven't necessarily changed, but the game has changed, right? And so what I would say is that I think how people are standing out, number one, obviously, I think you gotta tend to the basics. Like grades have to be solid, scores have to be solid, but how you distinguish yourself by getting some heterogeneous experiences, right? Like I would say now, like, somebody might have like a summer or two of research experience, but perhaps it'd be better served in terms of really testing themselves by taking a year and going and working on a start that they feel really passionate about, and taking folks through that experience, right? Or going and working on Capitol Hill for a year and actually driving that forward. I think that those kinds of experiences where you're saying, hey, how am I getting out and actually doing, right? And like, what am I learning in that process? That becomes a really interesting elements that then open you up long term, right? To a lot of different experiences. Said differently, right? Like if you spent a ton of time in medical school as a student body president, or you were a national leader in the Student National Medical Association, or you did 5 years of global health work throughout, and built an NGO out from nothing to something. Those are experiences that you are learning how to manage people, how to lead with influence and persuasion, how to think through budgeting, how to get people through hard times, how to handle crises. And that comes back, right? Like those are the folks who end up in residency like natural team leaders, even if they don't know all the medical knowledge, right? Those are the folks who disproportionately end up getting selected for chief residencies if that's what's important to them, right? Like at every step of the way, how are you thinking about how you lead others, how you manage others, and how you gain some of those insights? That's what accelerates, I think, in a bunch of ways once you actually get into training. I think the second piece is like then thinking through, okay, what are the paths that I have to go through to get there? And I think this is a question, I didn't mention this in our first question, but I did spend a lot of time, especially for graduate school and then for residency, thinking through, hey, where are programs where people they get kind of weirdos like me, right? Like there are lots of places who will be like, we want one camera, right? But like them being able to point to, oh, we've actually had like one camera in a year for many years, or there's like four of you guys that are all in this one class, and so we figured out how to support you. you come to HSS and like we'll let you go to McKinsey for 3 months, and then like you can go spend 3 months with Kevin Bozick, and sort of like this starts to like snowball, right? Like those are things that are non-trivial because again, you got to get through those years to get to the kind of place and the careers that I think all of us dream about or are inspired to be, right? So like when I was sitting in that space thinking of my heroes like Bob Lawrence or Don Berwick or Rashika Fernandez-Poulet or those that generation of leaders, Jack Geiger, uh, Carl Eisenberg and others, that was what they predicated themselves on really strong clinical training, but they also tended to, sort of convene or somehow find each other at the same kind of smaller set of institutions over and over again that had a knack for this, right? Like Michigan being one of those places, or obviously it's Harvard and Yale, sure, but like UCLA being one of those, or UCSF being one of those, or University of Washington, right? Or folks speak very passionately about being at Emory, right? Like there are places that just have that ethos of thinking. Penn, another one, like thinking about public service, thinking about the broader connectivity of medicine society, and then attracting folks who are future leaders or current leaders and able to play in that space, right?
Yes.
And so I won't belabor this further, but like I do think that piece is non-trivial.
Yes, yes. And obviously environment matters a lot. I was wondering as well, this is something I've been grappling with for many years now. For
Yeah.
people who aren't at those institutions, what what advice would you give them on how to enter this world? Because oftentimes it's chance occurrences, they were your teacher or they were your classmate and they were this amazing journalist and you just learned it from them and they took you under their tutelage. And I'm aware that the internet exists, but nothing beats the power of an in-person interaction. How do you overcome the potential hurdle of being at, some very, very rural place?
Yeah. Well, I mean, I think a lot about my own experience, right? Like I was, I got amazing clinical training at VCU, the Medical College of Virginia, but we didn't have a lot of that, that pedigree or that exposure, right? Like we're a good clinical school. And so I think of this like, number one, I like really looked around like my own institution to be like, are there people who are somehow connected to this space, right? And I was really lucky to find Dr. Steve Wolf, who happened to be one of this, giant in, public health policy and like on the U.S. Preventive Services Task Force and on the VCU Family Medicine faculty. And like, he ended up giving me the advice, like, he had gone to Hopkins and he had done the preventive medicine residency there and he'd done all this stuff. And I was like, at that time I thought, hey, I guess I'm probably going to end up becoming an academic health services researcher. So like, I want to do what you do. And like, after a year or so working with him, he's like, if you really wanted to do what I did, I wouldn't go get an MPH, right? Like, he's like, if I go back again, I'd go get an MPP at Harvard. And I was like, what's that? Right? Like I had never heard of this degree. I had never heard of the Kennedy School of Government. I had no idea, right? As a native Virginian, just who had not been exposed beyond knowing of Harvard as a concept. And like that, that one piece of advice, right, like opened up a ton of opportunity, and ultimately is also the place where I met my wife, right? So like clearly a lot to owe to a guy like Steve Wolf, and that was on a simple cold call from an email perspective. But what I found now is like, to your point, like there is the internet, and now that kind of outreach comes from like all over the place, right? Like I think you probably see this yourself. There's a lot you can accomplish with hustle in terms of just being on LinkedIn, presenting yourself earnestly, or finding an email and asking for advice. And I think what I have been consistently impressed by is that 9 times out of 10, the person you talk to who's the bigwig is actually going to respond and say yes, right? Like even when I have a mentee from the Kennedy School who's like going through job search stuff right now, and she was able to cold email Vivek Murthy, right? And like somehow got through his email filters and got an hour of his time, right? Like willing to go, like Will was willing to drive up to DC for a day, show some gumption and like chase that opportunity. And so I think while yes, it would be much easier to do that if you were a Harvard medical student, right? Or you're a UCLA medical student, or you're at the University of Washington, these things are like, people are open, right? And I think what you just have to recognize is that like you can build that connectivity, and you have to be very pragmatic around, hey, if I'm coming from here, right? If I'm coming from a rural space, if I'm coming from Marshall and West Virginia or stuff like that, then what is the track record from people from my school to end up at a residency program like a Michigan or a Columbia or a Penn or whatever? And what does that require? Because that's probably going to be pretty consistent, right? For folks who are coming from left field to some extent, we have to think really carefully about a ways, right? We have to think very carefully about those kinds of relationships. And then when we show up, we have to really we have to excel, right? So I think it's not impossible, right, by any means. But I think, sitting on these intern selection committees, sitting in fellowship interviews, sitting, even from a job perspective, lots of people come in and prove themselves to be incredibly capable, but it becomes much more of a curated and planned experience than I think necessarily others might find as a medical student at Yale, right? And so I think that's where you just have to be very, very pragmatic and a forward thinker around how to navigate all of that. I
Yes.
don't know if that makes sense, but it's like it is inherent in the hustle. And then when you're given those opportunities to shine, how do you play your cards? I'll give one very micro example. When I left for the Kennedy School, I would have been equally happy going into trauma surgery, general internal medicine, ENT, or emergency medicine, right? And I just started kind of thinking about, okay, knowing the question of where are the people that have done the kind of work that I want to do nationally. And at that time, I was very focused on federal health policy, right? Where have they trained, right? And that's a small subset of hospitals. And so then it's okay, logically, is it going to be easier to match into one of 5 general surgery spots or one of 55 medicine spots?
Yes. 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 Of
And
course.
that played out.
Yeah. Yeah. I think I froze here.
A little bit. It looks
Am I
like it.
frozen? Okay, here, let me try to redo this real quick. Goodness. Yes. Okay.
You're
Yeah.
back.
Yeah. So it seems like you gravitated toward internal medicine because they have more spots at the programs that you wanted.
Well, I mean, I really enjoyed my time on medicine. I knew coming into medical school that it was probably going to be internal medicine. I tried a lot. I tried to a lot of different things, right? I sat through 2 months of a physical med and rehab elective, and the residents were done at 1:30, and our elective was literally us watching Animal Planet in the resident room. And I remember, in retrospect, I should have been oh my God, what a chill life. Clearly, this is going to be awesome. But I was oh man, this is so boring when they're not doing anything. It was the
You
wrong
want the
reaction.
smoke, the drama.
Yeah, exactly.
Yeah.
But so then, so I went into my master's year, then sort of being okay, IM or EM, right? The numbers game are better here than obviously general surgery or ENT. And then I just reflected. I remember there was one morning in December that I woke up, and I think I had dreamt the night before about being back in the hospital. And I woke up and I just had the realization of oh, I really miss rounding, right? Which by
Yeah.
nobody says. But
Wow.
the piece was I was I wonder what happens when they go upstairs, right? And I kind of just knew then. I was all right, it's going to be IM, right? So it wasn't solely a ruthless exercise of deciding how to pick a specialty, but certainly that piece of it was informed, right?
Yeah, yeah, and your specialty looks like it was a combination of both personal interest and of how can I position myself to get into this space.
Yeah.
Yeah, so I did have another question generally about a little later in your career. So, then you went on to serve as the Chief Medical Officer of Value-Based Care Strategy at Oak Street Health. And before I lead into that kind of area of the interview, just as
Yeah.
a bridge, how did you navigate postgraduate life after residency to kind of start to enter this space? Were people approaching you at conferences? Did you cold email people? How did that work?
Another good question. So, I couples matched in medicine, my wife in OB. So I had an extra year to sort of quote unquote kill. So, which I assumed would be filled either with a chief year or with, where we matched for residency at Yale New Haven Hospital was also a host site at the time for the Robert Wood Johnson Clinical Scholars Program, which is now the National Clinical Scholars Program. And obviously a well-reputed, long-standing program that builds a lot of health service research leaders and folks who go off to do great things in federal government and state government and all sorts of things, right? So, in public health. So I was like, okay, I should probably do that since I'm here, right? So I think the first thing that happened was I went off and interviewed for this fellowship program, the clinical scholars, and it became very clear, both to me and all the people I was interviewing with at UCLA and Yale and Penn and Michigan or whatever, that like, yeah, I could probably do the work of becoming a health services researcher. But what I was much more interested in was like using the tools of health services research as the building blocks to go implement things, right? And so like they were like, yeah, you can do this if you want, but we suspect there's something else you want to do, right? So then in that panic after at the end of my second year of being like, oh, okay, maybe this thing isn't right, I like cast a pretty wide net. Like many students listening to this podcast, I thought about management consulting. I applied to this was the start of the emergence of like kind of sort of integrated hospitalist slash management jobs, right? That like 40% management, 60% clinical, something like that. So I was like, I applied for that and got an offer at Yale at my home institution. But then, having just been on the conference circuit, having, gotten a little bit of flexibility for my program to sort of meet some folks, I happened to, interact with the judge of an oral presentation that I was giving on a finance and public leadership curriculum we built at Yale for residents going through this intensive primary care leadership development track. And the judge told me, hey, this is a great idea. It'll never work, but you should monetize it and somehow sell it to Rosetta Stone, which was a training tool at the time that nobody knows anymore about for foreign languages. And I had been on Onk nights the entire week. And so now it was like 5 p.m., had been up for like 24, 25 hours, driven 3 hours to Maine, Portland, Maine to give this presentation. And I sort of was like, I don't know who this jerk is, right? But like, okay, we get to talking. And it turns out that he is like the, a number 2 doctor at this startup called Iora Health that had just been featured in the New Yorker by Atul Gawande talking about their ambulatory ICU model for superutilizers, using community health workers to in a non-fee-for-service environment to go off and produce like dramatic changes in the lives of some of the sickest folks, poorest folks out there. And they happen to be doing it with casino workers at the time in Atlantic City, as Gawande talks about in this Hotspotters article. And so one thing led to another from this like otherwise hilarious, somewhat contentious interaction with this judge. And that judge, Andrew Schutzbank, turned out to be my first boss at Iora. And I ended up spending 3 months of my last year residency with Andrew and with the team at Iora, taking care of super sick casino workers on the strip across the street from the Stratosphere in Vegas. In like the highest, the highest functioning healthcare team I've ever seen in my life or have ever seen since. Right. So, and I say that because it took a lot for a program to be willing to let me go to Vegas for 3 months. And I owed a lot of people call when I came back. And that's the thing. When you ask for these kinds of favors, you have to pay it back like double or triple and be really happy to do it. But so then when it came to, and otherwise I was thinking like Cameron, as you suggested, I need to go email 100 people. I should go do a bunch of informational interviews. Let me go see what to do. And instead I just kind of followed my heart. And I was like, this is the work that I want to do the most. And I have a sense that I'll learn a lot here. And I got really good advice from a mentor who said, hey, listen, when faced with a fork in the road, especially early in your career, before you have kids, before you have a bunch of things, just take the more radical path, right? Because you can always come back to health services research, right? I can always come back to that hospice job. I can always come back to the McKinsey offer that I got. I deferred it for a while thinking that just in case, right? But like, you'll never get this moment again. And that was what really set me down a path of, again, private sector work, which I was not anticipating, entrepreneurship work that I was not anticipating, but ended up being so resonant with so many different things I'd done in my career up to that point that I think just taking the chances and like going with your gut after that kind of preparation was really ended up serving me well in that moment. And I've kind of used that through line since in the journey to Oak Street.
Yes, yes. And that's really a very different approach than what a lot of medicine is traditionally about. That's a very conservative culture. as I'm sure many of the people on this podcast are aware. So again, it speaks to your multidisciplinary fluency here, where you're able to kind of bring in these values of hustle and risk taking from the management and private sector world and apply it to medicine. I think that's really laudable and exciting, and I hope the viewers take that out of this conversation as well. You
Well,
know,
but what I would say, Cameron, though, is just that like at that moment, I wasn't a private sector guy, right? In the
yeah,
sense that I was just a guy who had a public service degree, who like felt a gut instinct, but who like again in that reflection, I was like, oh, right, like from like my days as a fraternity officer or like a student government guy or like alternative spring break person, right? Like all the way through to like building other things, like there's a through line of sort of like building and trying new things, much like yourself, right? Like something doesn't exist, why don't I create it if it doesn't, if it's not there before? um there's a through line on curiosity, right? There's a through line on ambition, there's a through line on like sticky problems. And so like those things come together, you realize in retrospect, oh, there was all this preparation, but like probably a lot of it was just growing up the son of an elementary school principal and like an entrepreneur who like our weekends were spent like spreading mulch on playgrounds for my mom's elementary school and like vacuuming air filters, right, to extend the life of their lives, like, and like listening to their dinner table conversation about their employees and management decisions and realizing like, oh, that's what I've been dealing with the whole time. So my point is that like I think if I'm going to hazard a guess that many of your listeners are thinking about like, oh man, if I don't go get a Harvard MBA, right? If I don't go to Wharton or something, like nothing's going to happen. And all those networks are all great, and they've been very useful to me. But there's so much of the story within you that we don't take the time to mine, or we don't think about it until after the fact. And so I wouldn't necessarily say that like someone who's thinking about public sector or private sector but doesn't have experience on either side is necessarily going to be like cut out of that. You just have to think through, how does it relate to your own life story?
mhm. Yeah, yeah. And speaking of life story, I wanted to kind of explore the next section of your career,
Yeah.
which was then, you know, your, based on that experience you had then later on as the officer of value-based care strategy at Oak Street Health and your current role at Aetna Medicare as CMO. Can you talk about the importance of value-based care as you've come to see it and how it enables person-centered care for, the Medicare beneficiaries that you've started to serve?
Yeah, I think, Cameron, in a lot of unfortunate developments, I'm the system that we have is a reactive system, right? And people will talk about this in a bunch of motifs, talking about sick care systems or talking about, sort of fragmented systems, so on and so forth. But a lot of well-intended policy has left, and policy changes have left us in a place where the kind of care that our parents and grandparents deserve, coming back to the 4 C's of primary care that Barbara Starfield used to talk about, doesn't exist, right? Our care is not continuous. We rarely are able to make first contact with the same person that understands our story. We are not comprehensive, and like we are not patient-centered, right? So from that context, we fail every single day in American medicine to connect the dots and to just and honor people's worry and preserve their dignity in this work. And I would say that the past 15 years in value-based care, in building value-based care systems, in seeing what happens when physicians and nurses and behavioralists and pharmacists and community health workers and social workers and all sorts of folks actually come into a system where they feel like they're not just on a numbers-based rat race, but they're actually able to sort of say, oh, I can actually take some time, think about somebody, and implement a plan. And then their willingness to go do whatever it takes for people in a system that can actually incentivize or doesn't disincentivize, right, the work of being there for folks is actually incredibly powerful, right? So I'm ruined for fee for service care for the rest of my career, right? I've done a bunch of it, but like on the side and in other places, particularly as a moonlighter, because there's not always a lot of money in entrepreneurship. But like it is a difficult way to practice outside of a value-based environment once you've seen that, and once you've seen how freeing that can be in terms of being able to put people together to go solve problems, right? Some of the most important work that I've done has been in and around like spending time on a day-to-day basis thinking about highly complex patients and the various challenges that they have, and then going to meet them where they are, right? And using data to figure out that somebody's not returning any of our calls, but they are going to dialysis, and then showing up with a team at the dialysis center to demonstrate, hey, we've been worried about you, right? And we're at full risk for you. And so like we want to help you get well, right? Or knocking on car doors in a mall parking lot because we know that one of our members has a big diabetic foot wound and she lives in a Toyota Celica that's gray. But there's like, is it gray? Is it silver? Or is it actually a faded black? Right? Like, and like sort of figuring that out. So from that perspective, having seen the realized potential of what value-based care can do, I think at Oak Street, some of the most critical work and the most important work I'll ever do in my career was in and around how Oak Street, as a entirely value-based care primary care delivery system, was able to pivot in the pandemic because we weren't being paid full capitation while every other health system out there was worried about like how will they keep up their billing and their fee-for-service coding and the like and their volume. Our revenues were stable, so we were able to pivot to be like, what can we do to deliver food to our patients on a weekly basis so they don't have to go outside, right? What are we doing to stand up vaccination efforts, not just for our own patients, but for people in the zip codes that we live in that are often had incredibly high social vulnerability or area deprivation index scores, and therefore were often the zip codes that were most hit by COVID cases and deaths. So we'd vaccinate everyone from age 14 onward to make in partnership with city and county governments to make sure that we were getting towards community vaccine prevalence that would actually cause us to be able to withstand the full brunt of the pandemic, right? Like we were able to do so much in the public interest because we were just off of that gravy train, right? Of volume-based reimbursement. That having seen all that potential, Cameron, like I know there's a lot of work ahead to sort of make that scale nationally and like both in the public sector and the private sector. But when you've seen that and you've tasted it and you've lived it, especially as a practicing doc, it's just so enticing that it's very hard to go back.
Yes, yes. And you've experienced the impact that it has on, patient care and aligning the incentives really with
Yeah.
the long-term growth. And, you know, uh, this may be redundant, but I am curious if you can share other kind of scenarios where value-based initiatives can lead to measurable improvements in patient outcomes or even member satisfaction. I mean, I want you to hopefully paint a very large picture. Now, I'll give you a reason why.
Yeah.
I was on call with Mark Cuban on this podcast earlier from Shark Tank, and he was discussing his cost plus pharmacy, the drugs,
Yeah.
and I brought this up with one of an attending here at Georgetown, and they said, "Oh, we don't use cost plus drugs because they have 60 milligrams versus 61 milligrams, right? It doesn't match exactly the formulas." And he said,
Yeah.
"Oh,
Yeah.
that's an excuse, right?" So, a lot of the times when someone espouses or takes a side, um, you know, I, I want to give that person a chance to, you know, get ahead and parry or rebuke any potential counter arguments that can be made. So I'm wondering if you can kind of share examples. I know that I think this was on Health Affairs, or there was somewhere that posted something saying like value-based care is dead. And
Yeah.
a lot of people who are I mean, it's a contentious topic. So maybe if you could address some of those reservations people have.
Yeah. I think it's first off, Cameron, fantastic question. A lot of the challenges in value-based care today are in and around the translation of that promise of value-based care of like what it can be and what it can enable to the actual operationalization of it, right? And given that most of the care that's delivered in this country, particularly at the hospital health system level, right? Now 70% of primary care docs are employed by a major system like a health system or a hospital system or by a private sector entity. What we see in both primary care and specialty care is that we are sort of in the worst of both worlds from either a fee-for-service perspective or a value-based care perspective, right? In a lot of value-based care, which has been concentrated in Medicare Advantage, right, and to some extent in managed Medicaid, the work that is done, like there are two things you have to do, right? Like ultimately value is, outcomes divided by cost, right? What are we getting for what are we spending?
Mhm.
And so ideally, we would see superior outcomes, right? At the same cost or lower cost than we're doing. But in value-based care reimbursement models, because of how you want to deal, you don't want to disincentivize people from taking care of sick people. a lot of the actuarial methods that we used in risk adjustment and a lot of the bonus programs that we've developed from a quality perspective to drive quality improvement have resulted in a lot of work that has focused on that revenue side, right? Of let's get risk adjustment coding right and let's get quality gaps closed. But we can do all of that and like hopefully the clinical outcomes will come. But like often whether it's because we didn't expose enough people to risk to sort of say you're responsible for those outcomes, we've left a lot of folks as a payer, as payers, as governmental agencies, stuff like that, in terms of focusing on this side, right? Mm-hmm. So therefore, a lot of health systems maybe started down that operationalization of getting to better clinical outcomes, changing how teams are structured, changing how their workflows work, stuff like that, probably lost some money and then pivoted back, right? So when we ended up, I think 15 years in the value-based care experiment, is a situation in which there's a lot of practices out there where you're still seeing in primary care, especially care, 20 or 30 people a day for 15 or 20-minute visits. You're still churning through a bunch of notes. You haven't gotten an AI scribe yet. You had none of those things have happened. But then you're coming home and you've got 11 queries from a central documentation coder saying you need to change the language in each of your notes to better reflect what Medicare risk adjustment should be because we have some arrangement where we care about that. And there's like 30 quality gaps to close because we want to get that revenue. And so when we focus on outcomes, we start to see the stuff like an Iora, like an Oak Street, right? Like CareMore, the places I've been really privileged to work, and lots of others, City Block, ChenMed, others, Kaiser Permanente, where instead you say, if we're focusing on outcomes and we went to risk, we operationalized by creating time every day where teams are doing nothing but closing those gaps instead of seeing patients because that's effective work in panel management, right? Or where we say, we take an hour at the start of a day to go through all of our patients who are hospitalized or in ERs and build transition plans so to make sure that they don't go back, right? Mm-hmm. Or they don't readmit or these sorts of things. So without that connection from like intent towards operations, we end up in this middle zone that's incredibly difficult. And so value-based care, as a result, hasn't shown that sea change towards outcomes, towards actual clinical improvement, and therefore towards the eventual cost of care impacts that we want to see. We have lots of pockets of innovation. We haven't gotten to critical mass. So I think this next era of value-based care, driven actually by regulatory changes from a governmental perspective to try to reduce some of the dependence on risk adjustment revenue and to change how we think about quality to make it aspirational to do really well there and to focus more on clinical outcomes in those quality measures, like keeping people out of hospitals, like keeping their blood pressure under control, like getting their A1Cs under control, so on and so forth. This next era is going to be more make or break on whether we actually get to the place of not worrying about 61 milligrams or 60 milligrams, but worrying instead about how many days are we keeping somebody at home, right? How are we doing it actually titrating their SSRIs every 4 weeks like we're supposed to be, instead of forgetting and waiting till the next time we see then their PCP appointment, which is 6 months, if we're lucky, right? Like there's so many things today that in our fragmented system fall through the cracks because we haven't shifted the operationalization, even if we are theoretically taking on some value-based care revenue or risk or whatever, that this next era of focusing on what I think is going to be clinical stabilization is going to require that reoperationalization. And we'll see who actually pushes into it or not. But those, the critiques on value-based care are real. I think this next 5 years is going to be really important in terms of demonstrating whether we can scale those like small, buckets of innovation and outcomes improvement and make that durable across the populations.
Yeah, and I do recall you mentioning that you're actually a proponent of advancing a shift from risk-based reimbursement more toward clinical outcomes. I'm wondering if you can kind of build on that a little more, because a lot of people think of risk readjustment as the holy grail, as the reason that people will want to take on these disadvantaged patients.
Yeah, so let me give you an example, right? Like today, there was a lot of interesting activity in orthopedics in like the mid 2010s in and around the Centers for Medicare and Medicare Services introducing mandatory bundles for like hip surgery, joint replacement operations, and spine surgery. And so you saw actually orthopods make this incredible shift. And I would deal with them in hospitals, even when I was at CareMore Health Plan, where they'd be like, no, 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 I don't want this person to go to skilled nursing. Like, I have a new protocol. I have a whole thing. I can prophylax them from DVTs using aspirin and like all like very innovative, thoughtful things. Um, but like, I don't want them to go to SNF, and they didn't want them to go to rehab because in the bundles that they were being paid for by out of traditional Medicare, they would get dinged. That was money out of their pockets because they would have to pay out that work. And then we turned off that bundle program after a couple of years, and everybody kind of reverted back to normal, right? But so the trick is to say, hey, we know there's a lot of opportunity in musculoskeletal care today to like reduce waste and occasionally fraud and abuse, but also to help people through a program, right? Like, we have a lot of digital health solutions today that promise to reduce the dependency on surgery for folks who have low back pain or joint pain or whatever. But once you get through that digital program, if you still need an operation, you're sort of dropped back at the front desk again, and you have to figure out how to navigate this pathway yourself. Mm-hmm. So I think this next generation of value-based care instead says, hey, what's the end-to-end experience, right? Like, how do I start at a digital front door, go through digital physical therapy or occupational therapy, and like, learn biofeedback and a bunch of other things. But then if I get to a place where I need surgery, that I'm then plugged in through the right mechanisms into, let's say, Georgetown's, orthopedics group, and that Georgetown has been entered into enough contracts with the payers around in DC, Maryland, and Virginia that they're at risk for the professional and like institutional spend, like so hospital spend, ER spend, surgical spend, DME, right, post-acute, associated with all potential musculoskeletal conditions in this case. And so they've now, those practices, that Georgetown practice has a bunch of revenue from us because we're saying, hey, we spend $15 per person per month on musculoskeletal care today. You see 100,000 of our patients a year. And so here's 1.5 million a month to take care of all of our orthopedic care. And therefore now Georgetown has said, okay, we're not going to necessarily redesign the whole system, but we are going to create like a mini center of excellence. There's a couple of spine guys, and there's a couple of hip guys and joint guys, and there's a couple of shoulder folks, and there's one foot and ankle guy, and another woman who specializes in sports medicine and stuff like that. And they're going to be our team that really tries to do all our value-based care, right? Longer visits, more digitally enabled, taking more of those referrals, following them through post-acute, making sure they don't bounce back, doing all the things. So how we align the financial incentives in different ways, right? Outside of risk adjustment, outside of the quality, to say like, how are we giving you the skin in the game and the financial funding necessary to think about how you redesign your operations around longitudinal management and dignity preservation, then I think that's going to be a really interesting era for us. And we're starting to see that again with like, from a CMS perspective, with the new team bundles that are coming back into vogue. These are the conversations a lot of musculoskeletal departments and orthopedic departments are starting to have with us, thanks to the work of Kevin Bozick and others, in terms of thinking and leading through what this could look like, right? And beyond bundles, right? But to really say, how do we think about longitudinal management? That's a future of value-based care that I think is incredibly compelling, and that we are working with, at Aetna today to sort of say, how can we help affect that?
Yes, absolutely. And, about value-based care as well, I'm wondering, what are your thoughts on the risk-adjusted capitation model that's floated around? I remember you mentioned Kaiser Permanente earlier.
Yeah.
What are your thoughts on those as well?
I mean, that's what I've practiced in the last 15 years by and large, right? So I think, and I've, again, that career has been focused entirely on highly vulnerable, often duly Medicare and Medicaid eligible, or if not, folks who are just shy of Medicaid eligibility because they make $100 too much or something, right, from their pensions on a monthly basis. And so these are folks for whom like social, environmental, and like policy stresses are really real. And so seeing how teams can reorganize in the primary care setting from reactive to proactive in terms of work, in terms of management, in terms of trying to keep people out of trouble, has been the most inspiring work of my career, right? We see, again, and I think we have to get away from, it can only happen in self-contained environments like an Oak Street or a Iora, or it can only happen when I change the entirety of a 120-person primary care group at, let's say, at Georgetown. But like, can I like specialize in different ways to enable the kind of operational changes that have to happen for folks who want to do that, right? For like there may be those 10 orthopods that I just talked about that want to live this kind of lifestyle and do a different kind of practice. And then there's going to be another 10 orthopods who are just like, I just want to operate all the time, nothing else. Let me go. And can we actually start to create that kind of specialization for folks? Because in a capitated system, Rishika Fernandez and a bunch of other mentors of mine from Iora and from CareMore have often said this, like, capitation equals freedom. And from a practice perspective, there's all sorts of cool things you can do once you're on a capitated environment, right? Just like the stories we were telling from Oak Street in the pandemic. Risk-based capitation, I think, is a core component of any model that we are going to advance to change the way in which American healthcare delivery is changed for the better, right? But it's a matter of like making sure that we're focusing risk-adjusted capitation models on the clinical outcomes and clinical stabilization, and less so on the risk adjustment part. And I think that's going to be the interesting gambit.
Yes, yes. And that's the ticket to the future of value-based care and the implementation.
Yeah.
Uh, final question as well. I want to be respectful of your time here. Um, I I wanted to know if there were lessons that you've learned throughout your career that, this whole place is just um it's very new terrain, almost like a minefield, and as a student you're kind of tiptoeing here and there and trying to figure out your way. And my dad almost likens it to walking through a fog. And the more you walk, the more you see, but things just get obscured all around you, right? I
Yeah.
mean, no one really understands where the future of medicine is heading or any of these things. What are some lessons you've learned or advice you have for our audience?
Um, and that's another hour. I do think I come back to that piece of when faced with, you know, two paths, take the more radical one,
Yes.
push yourself out of your comfort zone. And to your point earlier about like, cold emailing and taking big swings, if you want to talk to Atul Gawande, email Atul Gawande and see what happens, right? If you want to talk to Mark Cuban, email Mark Cuban and see what happens, right? Those often land at a far better batting average than what we expect,
Mhm.
right? So I think that those two lessons together, Cameron, become super crucial in terms of just saying like inherently we are people who either become creatures of habit or we are people who become creatures who are constantly asking, trying to figure out what they don't know, right? And challenging themselves to reaffirm or change their own convictions. And I think in this world, you probably want to be the latter, not the former. And so you do that by building that muscle memory, right? Of putting yourself out there, identifying different avenues for growth, and then picking the one that seems harder or picking the one that seems more, more off the beaten path,
Mhm.
and sometimes failing, right? And that repeated exposure to that kind of work and that kind of experience, I think prepares you for hopefully a 40 or 50-year career in just improving healthcare and the dignity that we provide to people in this country. So that may sound trite, but in the time frame that we have, those are the lessons I think are most resonant for me.
Yes. It's not the mindset, it's the direction that you're
Yeah.
searching for. Yeah, or it's not the direction, it's the mindset. Sorry.
Yeah, because the direction can shift a lot, right? Like you go this and you go finally go this way, right? And everyone's had that moment, right? Where they're like, you see so much in these narratives, especially from really great physician leaders, where at some point they had a denouement, right? Like they were in that valley of despair from the Gartner hype cycle, and like I just talking to one of my very close friends who's like in that place right now with the startup that he's building, and he's also doing hospital shifts every single week, and like working his butt off in three other side jobs because he's paying everybody except himself, right? But he believes in the startup, and so he feels like he's doing all this, but like the natural arc may still be going this way. And as long as you know that that arc is going in the direction that you want to go, and hopefully bending in them towards moral justice, then I think you're winning.
The arc of history, yes. Yes,
Mm.
stay true to your thesis. And yes, I appreciate this conversation very much. It's been a pleasure having you on this show. And yeah, I can't wait to see what you're going to do in the future as well. I'll
Likewise.
follow what you do as well. And yes.
All
Yes.
right, man. Well, the brighter shine. I suspect the brighter star will be the person I'm talking to on this screen, and probably all of us will be working for you one of these days, man.
No, no.
Super excited.
The brighter star will be the sun when it rises after my night shift.
Well, try to get some sleep if you can.
Yeah.
And this has been a blast.
Thank you so much. I really appreciate it, and I am sure our audience appreciated it as well. So
Perfect.
thank you.
All right,
We'll keep
man.
in touch.
Go
Thank you.
Huskies.
Appreciate it. Go Huskies.